You are the Canadian Donation and Transplantation Research Program. You are CDTRP.
The CDTRP is a network of more than 400 clinicians, senior, mid, and early career researchers, trainees, patient, family, and donor partners, and 100 partner organizations. Our network has supported 275 collaborative research projects and has mobilized research into policy change, legislation, commercial products, and improved knowledge for patients, families, and donors. Every year, CDTRP supports between $30 to $40 million in grant applications, something around 60 to 70 individual applications. You are CDTRP. These achievements wouldn't be possible without your hard work.
CDTRP Research Services is a platform that supports principal investigators to develop high-quality research in donation and transplantation. We work hand in hand with CDTRP investigators to maximize the effectiveness of research teams through support with funding development, project management, patient, family, and donor partnership, knowledge mobilization, events, and trainee support. Across the 5 research themes, we help teams mobilize new knowledge to ensure patient-family donors, healthcare systems, partners, and stakeholders equitably benefit from research results.
If you are a basic scientist and would like support with your knowledge mobilization plan, if you are a busy clinician scientist with limited time for research but would like to run a multi-site study, if you are an early career researcher and looking for collaborators to help with your grant applications, if you value patient, family, and donor engagement, but are not sure how to find the right patient partners or what role they will have in your project, if you don't have full-time research staff but need support,
we are here to help. Our experienced management team can support you at every stage of your research in donation and transplantation.
Now you are probably thinking, how can I request CDTRP Research Services support? The answer is simple. Go to the CDTRP Research Services Platform website, fill out the form to request support, and we will get in touch with you to discuss your needs. That's it.
We.
Nous.
Noi.
Nos.
Emis.
Nosotros.
Menk.
Piano. We. Piano.
Our CDTRP, and we will drive research advances so that every wish to donate is fulfilled and transplantation becomes a lasting and sustainable cure.
You are CDTRP.
Email us today.
Thank you, Ruth and Len, for your presentation. And before we get to questions, we're actually going to move to our second presentation and then have a joint Q&A session afterwards. Just a reminder to everyone, please feel free to ask your questions to the panel using the chat box. You can also raise your hand or send a question directly to the CDTRP Q&A in the participants list. I'm now pleased to introduce our second set of speakers for today for their presentation, Clinical Trials Landscape in Canada, Barriers and Motivators Impacting Patient Engagement. So Linda Hunter is the National Coordinator for the Stream for Community Partners and Patients with the Canadian Consortium of Clinical Trials Training Platform, CANTRAIN for short. Linda is also a patient and has lived with chronic disease for years, making her an excellent patient engagement research ambassador for the CIHR. She has co-developed online educational modules for patients and researchers about patient engagement in research. And Dr. Stuart Nicholl's is the Strategy for Patient-Oriented Research Program Facilitator in the Office for Patient Engagement in Research Activities at the Ottawa Method Center. In his capacity as SPOR Program Facilitator, Stuart consults with researchers to provide methodological guidance regarding all aspects of patient-oriented research. And in addition, Dr. Nicholls provides training and education on patient engagement in research and actively contributes to research in this field. So over to you, Stuart and Linda. Oh, Dr. Nicholls, I think you are muted.
Of course I am. I've only had 4 years practice, sorry. I will just share my screen now. Hopefully you can see my slides.
Yes, we can.
Excellent. Okay, so thank you for that introduction, and thank you to Len and Ruth. That's a great foundation that I can hopefully build off in the next few minutes, and I've got my timer here, so I will be sure to keep to good time. So I was asked to talk about the landscape and barriers and motivators impacting patient engagement in clinical trials. So I'll start by talking a little bit about clinical trials and patient engagement, particularly some of the terminology which we already sort of alluded to in the opening presentations. I'll then talk about a move from advocacy to more sort of partnered or institution-led engagement and the various motivations for engagement in clinical trials. And then I'll finish by talking about the benefits and some of the ongoing challenges and barriers before handing over to Linda. So very briefly, I just want to sort of go through this because I'll probably slip between some of these terms as we go through. So patient engagement is the common sort of terminology we use in Canada, but in the UK and elsewhere in Europe, you might hear about patient and public involvement or patient and public involvement and engagement. And in Australia, particularly, the terminology is more around consumer engagement. So for the purposes of the talk that I'm going to give, I'm going to use these to mean the same thing. Some people may argue differences, but for the purposes of my talk, I'm going to use them interchangeably. And then just a note on the word patient. I'm going to take my lead from the Strategy for Patient-Oriented Research in Canada, which uses this term as an overarching term, inclusive of individuals with personal experience of a health issue, which includes informal caregivers and family members and friends. And partly because of the language around patient, what you might also see now is the term person with lived experience or people with lived or living experience. So again, I'm going to use the word patient, but this is, I want you to take it that this is a broader use of the term rather than a very narrow definition. So that said, what do we mean by patient and public involvement or patient engagement? And Ruth's already sort of talked to this. We're talking about that active collaboration. And this is a sort of internationally recognized aspect. So it's not just in Canada, it's actually part of the UK definition of their terminology as well. So it's about working together, researchers, patients, and family members to design and conduct research. It's not about study participants. And I mentioned briefly this transition over the last sort of 40 years, maybe 50 years, where a lot of the early work around clinical trials was advocacy. It was patient advocacy about trying to get into this space to be allowed to sort of inform trials and say, we need to have trials that are meaningful to us and actually reflect our realities. And what we've seen is a transition to more partnered approaches where patients, organizations, and research institutions and funders are working together, to now it's sort of being embedded in many of the areas of work, including industry, funders, and actually journal publications as well now. And this is, along with this, we've seen a growth in infrastructure to support patient engagement in clinical trials. You'll see on this slide a number of sort of entities that support patient engagement, including the SPOR support units and the SPOR disease networks, which aren't necessarily specific to clinical trials, but do a lot of work to support patient engagement in the clinical trials space. More recently, we've seen direct investment and support for clinical trials, including the Accelerating Clinical Trials Consortium and the various clinical trial training platforms, which includes CANTRAIN, and you'll hear a little bit about that from Linda later on. And so I said I was asked to talk about the motivations for patient engagement in trials. And again, we've heard a little bit about this in Ruth and Len's presentation, but I just want to expand on that because, and again, these are not mutually exclusive, but sort of common sort of dimensions to motivation. So in the sort of yellowy orange, we have what might be considered more intrinsic or moral or ethical rationales or motivations. So the top one is very much about, if someone is going to be affected by something, they should have a say in it. It's about that value, that moral piece, that if I'm going to be affected, I should have a voice in that process. Below that is a sort of larger societal change. It's about citizens and the role of citizens and the rights of citizens and empowerment. On the left, in the sort of blue color, we have what we might think of more instrumental or practical motivations. So these might be external motivators, like funders now require us to do it, or publishers require us to have patient engagement. But it might also be about practical things like, we feel that patient engagement will improve the quality of the research we do, the relevance of the research we do, or may help increase the uptake of the research that's conducted, and ultimately improve health and health systems. And as I say, these are not mutually exclusive. So we may have a combination of these in our reasons for engaging with patients in clinical trials. And you see this in the original document from the Canadian Institutes of Health Research when they set up their strategy for patient-oriented research. And when they talk about clinical trials, the first point they make is the disconnect between sort of what's perceived to be a focus on trials for new drugs versus other forms of intervention or resources that might be more relevant to patients, families, and caregivers. So again, that more on that sort of moral side of doing research that matters to people. Their second point is more about that sort of instrumental piece, and it's about outcome measures. So measuring endpoints that actually matter to people within trials. So again, as I say, it's more that practical quality kind of motivation. So you can see that even in that document, there's multiple motivations about why we should be engaging with patients in clinical trials. And then when we look to the literature, we're starting to see more and more work that's actually examining this question. And again, while it's not, you know, one way or the other specifically, what we see is a sort of trend where for patients, families, and caregivers, the motivations tend to be aligned with those moral, intrinsic kind of pieces. So they want to improve the care of future generations, health outcomes, improve the system. It's very much that altruistic kind of piece, although of course quality of research, improved research, minimizing burden within research also come through. And similarly on the researcher side, we still see those goals of improving the care for patients and their health, but we also see a stronger emphasis on those instrumental reasons. So it will improve my research, it will improve recruitment to my clinical trial. And obviously that hopefully translates into better uptake and things, but you see these practical elements also coming through. And again, the funding requirements and so forth also play a larger role. And so we have these various motivations that often overlap and maybe multiple. And so when we try to assess what the impact is, we have to sort of factor in what our motivations are, because depending on the motivation, we might want different evidence to say that the patient engagement has had an impact. So for example, I've just picked a couple of examples here. You know, if it's societal change and empowerment, we may want to ask, did the research improve the health outcomes of the patients or health systems at that level? And so we may need to collect evidence that reflects that piece. if our focus is more on that moral aspect, did people feel their voices were heard? We may ask different questions to assess whether the patient engagement had an impact. And then finally, if we want to look at improved quality or relevance of research, we may ask different questions again about how do we assess quality of research, its relevance, and so forth. So all to say, this points to this sort of more complicated piece where we try and assess what the impact of patient engagement is in clinical trials. And when we look to the literature again, what we see is a lot of work around the sort of more instrumental impact that patient engagement has on clinical trials and clinical research more broadly. So documentation of the sorts of changes that were made, again, Ruth pointed to this, changes to the recruitment materials, those sorts of things. But we also have sort of increasingly summaries of this literature, so reviews that capture more than just a single study. And again, they point to similar things, these very practical aspects, but also we do have some research around whether patients feel their voices are heard and things that promote that. So we are building an evidence base. One particular area where we actually have good evidence now through several reviews is that patient engagement in the design and conduct of clinical trials can improve recruitment, particularly where that engagement is around those recruitment materials and that process. So we do have some good quantitative evidence of that instrumental impact from the literature. So what are the ongoing challenges and maybe some of the barriers? And I'll finish on this section before handing over to Linda. So one of the barriers is, or one of the challenges, we still see relatively low levels of patient engagement reported in the clinical trials literature. These are just, again, 2 reviews that found very low levels of reporting in the trial reports. However, we need to sort of just caution that a little bit, because in work that we recently undertook, we surveyed trial authors about their patient engagement, and we compared that with their trial report. And what we found was, amongst those who said they had engaged patients as part of their trial design or conduct, 75% of them did not report it in the trial report that we'd actually approached them about. So there's this disconnect, it seems, between engaging patients or saying that they've engaged patients and actually reporting that. And so we need to understand what the barriers are to actually reporting on patient engagement in clinical trials. And even when we have reporting, what we see is that there's a sort of emphasis on some of those practical pieces again. So intervention development, recruitment, input on the outcomes that are selected, less so on what are the research questions we should be addressing, dissemination or implementation of research findings after the study. So again, I think we need to look at this and say, are there barriers to doing some of these, engaging patients in some of these pieces, such as the research question to be addressed, and understanding those and then developing solutions or ways to break down those barriers. And then finally, just an example here is that as we've had more infrastructure and investment, our creations of tools and resources have outstripped our use of them. So we have a lot of tools such as core outcome sets. So core outcome sets are mutually agreed upon outcomes developed by researchers, patient partners, clinicians, that should be collected in every clinical trial in a particular area. And what we see is, despite hundreds of these being developed, the uptake of them really varies depending on the area, from almost no uptake, so meaning no trials in a particular area virtually are using them, to very high uptake in some other areas. So again, understanding why that's the case, what are the barriers in some areas, and why are there less optimal uptake. So I'll finish by just summarizing and saying, we've had this move to more institutionalized patient and public involvement or patient engagement, which brings with it different motivations. Sometimes these may be multiple, and the evidence we have of impact of patient engagement in trials depends on that motivation. And so we need to think about maybe multifaceted assessment and how we can capture data. And as we've had this move maybe from why should we do patient engagement to how should we do patient engagement, we've had a proliferation of frameworks, tools, resources, but actually the use of those seems to be lagging behind. So we need to look at what the barriers are to using these resources, or to even engaging with patients in key areas like question development, and develop approaches to mitigate those barriers and challenges. So I'm going to stop sharing and finish talking, and I'll hand over to Linda.
Thanks, Stuart. That's great. Welcome everyone, and great to see everyone. Manuel, I sent you a little message there. If you could pull up my slides, I was having great connectivity problems. I only got in more than halfway between Stuart's. Thanks so much. So sorry about that, but I'll ask you to put it, and just go through. So I'm going to continue on. My name is Linda Hunter. I'm going to talk a little bit more about making this pertinent for patients. And Stuart covered some phenomenal aspects of patient engagement kind of in research and clinical trials. But I want to take it a step further and talk about practicalities and what that looks like in, in real life as we're doing this. So we'll just move on. And some of the objectives I want to cover today, I want to discuss a little bit about what patients think about patient partnership and research and clinical trials, and describe some research, in particular CANTRAIN, which some of you might have heard about, clinical trials training platform that I'm involved with as a patient co-investigator, and introduce some of the work that we did to build not just capacity, but trust and relationships to get down to actually doing some work that will help us all in clinical trials in Canada, and then finish off and discussing how we can better support patients to do this great work. So moving on, who am I? I have a very varied past. I've been in healthcare for a long, long time. I've worked as a clinician, an educator, a nurse, an administrator, an executive, etc. But right now, I'm really, for the last 6 or 7 years, I'm working as a patient partner in research due to diverse circumstances that caused me to now live with chronic conditions that cause chronic pain. So I'm very well versed to be positioned to understand the health side, understand the research side a little bit, but more importantly, it was quite a shock to see the patient side when I started working in patient engagement and research, excuse me. So moving on, we know, and Stuart covered a bit too, what patient engagement is. And I really like the meaningful and active collaboration set out by CIHR. So what does meaningful and collaborative mean to you? And what does meaningful and active collaboration mean to me? And I think it sometimes means different things depending on who you're speaking to. Hence, Stuart bringing forward to us, it's not very often that patients are engaged way up front with strategic thinking, blue sky thinking, and actually development of research questions. So moving on to what some of my patient engagement and research partners stated, we'll just move on to the next slide. I asked them, well, what is patient engagement to you? And they said, it's really active involvement, but active involvement how I believe it, what it is to be. And it's in the full research process. It's not just at the end in dissemination, it's actually starting up front at the beginning. And we want our research partners to value our insights and our experiences. And our experiences is also expertise. It's not patient or people with lived experience, it's people with lived expertise. And we want to have a meaningful role in shaping that research agenda, because any research that's done, any clinical trials that are done really benefit people like me at the end of the game. So we're really well versed in being interested in the outcomes. So to that end, we can help with spreading those outcomes. And I really feel that sometimes our patient organizations or disease-specific organizations aren't used as well as we could for getting outcomes out after clinical trials are done. So again, we always say, the importance of transparency, communication, two-way communication, collaborating, but it's really researchers to patients and patients to researchers, but it has to continue throughout the whole process. And I just want to give some examples of what that looks like. So patients are involved in many, many ways in Canada and international, from grant reviews, education at the undergraduate level and even beyond, knowledge translation. But I really want to focus on research. The picture here has a conference that we had for CANTRAIN in February. And of the people here, Andre Picard was the moderator, and we have 5 patient partners in that slew of panels. So this is what we like to see, patient partners with our researchers and with our clinicians kind of co-presenting. But I'm going to be focusing on research today. So moving forward, what do I do in research? I do a fair bit, and I could talk a lot about different things that I do and what I think is successful. And please feel free to take a bit of a look here. However, I want to specifically talk about CANTRAIN and the CANTRAIN experience that Stuart and I are both involved in over the last 15 months or so. So looking at, first of all, some of you might know CANTRAIN, some of you might not. It is one of the CIHR-funded clinical trial training platforms across Canada. And CANTRAIN specifically is about training in clinical trials. So it's specifically free tailor-made accredited programs for anyone in Canada in 4 distinct streams of learners. And we'll talk about those in just a sec, but it includes patients and community partners. And from this, we have different levels of training, kind of a foundational level, and then going on to more advanced levels. And the training is sought to be competency-based in that we're really trying to change behaviors based on education that we're giving to these different aspects. There are salary awards and internships, and while very, very important, it's not what I'll be focusing on today. So moving forward on CANTRAIN, I really just want to talk a little bit about the mission and vision. And the vision is to develop, conduct, engage in, and benefit from clinical trial research. But that's for everyone, transforming how Canadians are really looking at this. We don't have high participation rates. We do very poorly with co-partnership with researchers and patients. And overall clinical trials really do benefit from being better done and better coordinated and simplified to a better end in Canada. So we really want to have an inclusive educational curriculum that will allow us to do that. And that's what I've been working on with my partners for the last, over the last year. So moving forward into our programs, we have one that is for the graduate and postdoc trainees, so master's, PhD, and postdocs. We also have one for clinical research professionals called many, many different things across Canada, but these are the people that lead and operationalize the clinical trials in the settings that they're doing them in. We also have a stream for trialists. It's people that are clinical researchers, the clinical scientists that are, the PIs of the trials. And then we have one, we call it partners, and it's for community partners and patients, but it's also for the general public, for people that take care of other people, caregivers, health charities, for organizations that are disease specific, for people that write about health, for people that work in social media about health, and for marginalized populations as well. So it's a very, very diverse stream. And when we're thinking about creating education for a diverse stream, there's some things that have to come to mind from that. So moving forward, we have taken something that exists already. It's a core competency framework. It's for clinical research professionals. However, on the left-hand side of the slide, it's what we are using to align competencies of where we want to see behavior change so that the objectives of our training really fit with that. And I will suggest to you, it's a little bit hard to see there, but ethical and participant safety, as well as aspects related to data management, leadership, teamwork and communication, and other aspects in these domains of competencies align very, very nicely with the patient and the public and our community partners. So we are learning to create ideas of who it is, the audience we want to reach, what that audience wants, and then therefore what we have to create or source to be able to feed them information that is appropriate about clinical trials. And I want to talk a little bit about how we do that. So moving forward, if you haven't gone on the website, www.wecantrain.ca, please do so. Right now in the Common Core Foundation, there are 11 different courses. They're in English right now. They'll eventually be bilingual. They are free for anyone in Canada that is a patient or community partner or a member of all the other streams, the other 3 streams that we're serving as well. So there's a welcome and introduction and orientation to using the learning management system. There's 3 different regulatory courses that you can take, and there's 11 Common Core Foundation courses that are very, very diverse, but they're all about clinical trials, and there's one specifically about patient engagement in research. So we're really trying to increase awareness through knowledge, but by making people more competent in those 4 streams about clinical trials. So please do take a look. That's my go-to to start doing those courses. But I want to talk a little bit about the 4 streams. So just moving on, we can actually go through this slide and just move on to the next slide over after this one. Thanks, Manuel. Sorry for that. So I want to give about an introduction to Stream 4 and who we were and who we are now. So we started in January 2023 with an idea that we needed to have partnership across Canada with researchers and patients to say, where are the gaps and where are the challenges in clinical trial education in Canada, and how can we move forward? So I created a working group. The working group is co-chaired by myself as a patient partner and by a researcher, Dr. Tina Fahim from Toronto. Some of you might know. She's very, very well versed into patient engagement and research expertise. Initially, we only had researchers and clinicians, so I reached out across Canada, and we now have 8 family and/or patient members representing diverse diseases in different parts of the countries and different aspects, associated with equity and EDIA. That team met for monthly right through for the first almost 8 months of our inception, and that allowed us to get to know each other. It allowed us to build relationships, and it allowed us to build trust. Because when working with patients, if you don't understand the patient's story and why the patient is there and what the patient wants as a value proposition out of working with the research team moving forward, you can't speed through that and just get to what you have to do with your deliverable. So we took the time to co-develop a terms of reference. We actually used the template of the one from CIHR Institute of Musculoskeletal Health and Arthritis, because they have an excellent one, and it was very, very good to move forward from that vein. And that allowed us to get down to the work and actually have Stream 4 meetings. So we now have people, we have a team lead. Stuart is our team lead, along with Carolyn Jost, Dr. Jost from New Brunswick. We have a national stream coordinator, that's myself. We have clinical research educators, and they're from diverse places in Canada who have expertise in clinical trials and educational curriculum development. And we have advisors helping us along the way. We've had a few of those over the last year. And most importantly, we have patient partners that work with us. The patient partners that work with us meet with us bi-weekly and more often by email communication. And they're all paid an honorarium compensation as indicated by a voluntary basis and following CIHR guidelines for hourly payment for those compensations. But you can see our Stream 4 members are very, very diverse. And we're right now focusing on patients and family members and essential caregivers. So I see some questions coming through, and I just see one from Sandra. Is this national then? Yes, it is national, Sandra. All aspects of all 4 streams are national. So moving on to the next slide, we really wanted to make sure that we had engagement and consultation and collaboration. So it wasn't just seeking to say, here's something we've developed, what do you think about this? So our work group now meets quarterly. We're actually having a meeting again this afternoon, and they give us guidance and phenomenal counsel over everything that we have sought to put forward. And I'll give you a little bit of an explanation of what we're putting forward. But they really drive the advancement of the curriculum that we're doing for our stream audience. But the goal of working together with both our Stream 4 team, which meets either weekly or bi-weekly, in our work group 9, CAN partners, what they call themselves, is to build and create partnerships. But in doing that, we want to make sure that we are meeting the end goal of creating clinical trials training. So we want to prioritize patient engagement aspects and best practices, but we're not teaching about patient engagement. We're teaching about clinical trials and all aspects of trials throughout the whole continuum of trials and research, embedding the values of patient engagement and equity, diversity, EDIA perspectives. So this really is allowing us to have a trusting relationship to move forward. The 2 things that I'll say, though, you have to take a sufficient time, all of us as human beings, to invest in the relationship building and to invest in trust. If one doesn't do that, in my mind, one's not going to be successful with the team moving forward. There also has to be a consistent feedback loop with the team, knowing what we're doing, where we're going, what we're developing, bringing it back to them, and having an appropriate feedback loop that is an approval loop as well. So moving forward, some of our milestones that we've seen over the last year or so that I want to highlight. We started our project last year in January, moving to March. That really got us building up to where we are. We established the stream in a very good way just over a year ago. We curated educational content and resources nationally through our partners, our patient partners, and through their network, and also through SPOR and other patient disease and patient organization networks. from that perspective, we had a kind of a list of what's out there and what some of the challenges and gaps were in educational perspective. So last September, we created a national needs assessment survey. We took it from a list of patient organizations that CADTH, now the Canadian Drug Agency, uses, and we added through our network of patient partners all disease or patient organizations that we felt weren't on that list. And we sent it out to them and asked them what they thought is out there in clinical trials training, what's available to patient partners, what they've seen, what they've done that was really good, and what was missing in some of the barriers and challenges. We also asked them if they're interested in working through with us. So from that perspective, we created a list of different courses that now have become modules. So I'll just move on to some of the work that we're doing right now. We created substreams, and in our substreams, it became apparent that there's a lot of good stuff out there in the United States, nationally, in Europe, and in Canada. However, for people like myself that have been involved maybe a little bit, but not that much in patient engagement and research, there's also gaps and things not missing. So we listened to that, and those gaps seem to be information about patient participation in clinical trials and then patient partnership in clinical trials, so that we're separating those two. When we talk about clinical trials, we're not just seating onto the patient as a participant. There's also a big gap in how to do advocacy in a good way. What is advocacy? What are the skills you need? What are the soft skills? What do you have to know about politics, etc.? So patient advocacy in clinical trials to help lead the strategy and direction. And then very important and very innovatively, creating a patient research fellowship for patients so that researchers can see that patients have a certain level of competency and knowledge and expertise that is certified, that says they're able to co-partner appropriately with researchers in clinical trials. So moving forward, some aspects that I just think that we always have to remember, there's always going to be a power differential. And yes, every patient's different and everyone comes with different life experience, professional designations, and what they've done. But when you're working as a patient partner, there's still a differential between the researcher and the clinician and the patients. And we just have to be aware of those. We have to be aware of dynamics associated with influence, decision-making power, that patients don't usually hold the power, and we have to appreciate that we have to help set an equal tone to allow this trust to go forward so that people are not exploited and that we make decisions in a collaborative manner. So moving on, part of the aspects of power also relate to the vulnerability of patients. And when patients share their stories over and over and they're part of clinical trials or a research team, they're coming there from a point of need, a point of want, and a point that can sometimes cause trauma. So trauma-informed care is very, very important because there is emotional vulnerability and other aspects like tokenism, marginalization. So we have to make sure that we're very genuine. We have to recognize that. We have to compensate people appropriately, and we have to make sure that people are supported. So I just wanted to touch on the power and vulnerability. It's something I think that we have to really go into in greater depth. So I'd like to finish on how can you help patient partners and some of the key takeaways. So really support people through different ways. I live with chronic pain and I can only take so much before I have to get up and move around or take a rest that people might not take at the same time that I do. So things as simple as how meetings are done, when we have breaks, how we do them, what options we give to people are very important. Creating safe spaces so that there's no disdainful type of feedback that's coming forward so that patients feel that they can speak up, that they have to have that trust. It's really good to have one point of contact, and that one point of contact can also ensure a feedback loop happens. You write or you co-write a grant with someone and you never hear about the grant. Well, who's the person that's getting in touch with all the members, including the patient partners? I really want to highlight there has to be executive support. If this does not come from the top with support and what that looks like, and that they're living it on a daily basis and fully understand patient engagement, it's going to be very challenging to move it forward. Listening is good, but listening to understand, not listening to respond. And really, when there's a conference or anything that's going on, try as much as possible to have patient co-presenters, just like Stuart and I are doing today. And we thank the organizing team for that. And please introduce us to each other and introduce us to others. So my key takeaways and some of the mountains that I will die on is that every single clinical trial one day has a patient co-PI as appropriate, that budgeting for research has a line for patient engagement, that all patients feel supported, whether they're participants in clinical trials or partners in research, and that we teach about patient engagement at the undergraduate and graduate level in school, not just in the health field, in other fields as well. And then that way we can better align patient engagement in research and clinically, which a lot of people are trying to move forward to, and that research ideas, blue sky thinking, research questions, and strategy are led by patient input and guidance. And I've seen a fair bit of hope on that. So I think I might have finished, or my key takeaway is people are just the same. We're patients, we're people, we're just like you. We have lives beyond that. And we know our disease is best, and we really want to contribute to research because it helps us. But patients have expertise, not just experience, and just have that acknowledged. So thank you very much. I'll finish on that.
Okay. Well, thank you so much, Linda and Stuart, for your phenomenal presentation. I'm going to ask that Ruth and Len rejoin the conversation, and we're going to have a 15-minute Q&A for our first 4 speakers. Just a reminder to everyone, please feel free to ask your questions to the panel. You can use the chat box, you can raise your hand, or you can send a question directly to the CDTRP Q&A in the participants list. And with that, I'm going to open up the floor for questions. Okay, I also have a few questions of my own, so I guess I will get us started then. My first question is, would you be able to recommend any good resources to help break down some of the barriers to patient engagement in clinical trials? And this question is for everyone, but maybe if Stuart, you could get us started.
Sure, and I see Sean and Sandra have their hands up as well, so I'll be brief. Yeah, so there's a lot of resources depending on sort of what areas people are interested. So there are tools. There's something called the Perceived Research Burden Assessment tool, which is like a short survey, and it sort of assesses logistical barriers or burden, psychological and physical, and that can be used with patient partners by trialists to sort of preempt some of the potential challenges in their trial design and get feedback on that. Organizations such as the Patient-Focused Medicines Development Organization, as well as Transcelerate, have developed sort of guidebooks with sort of guidance and information there. So I'd also say things like the Accelerating Clinical Trials Consortium has a patient and family engagement group. So again, a go-to resource there, and you can reach out through the consortium. So yeah, various resources available.
Okay, thank you for that. Maybe we'll go Sandra, then Sean, and then I think there's a question in the chat.
Yeah, so first of all, I'd just like to acknowledge Stuart and Linda for your excellent presentation. I've had the pleasure of working with Stuart in Ontario SPOR Support Unit. And I think it's amazing. I did some work with Clinical Trials Ontario and was interviewed by Maureen Smith, I think it was like 3 years ago. And it was just us starting to talk about how patients can be engaged. Like Leonard started at the beginning, a lot of times we're just like, you know, we're part of the trial and we're going there. But the fact that if we can help design it, just like any other research, it's important because, you know, we sort of know what to expect, like something like how often we come back into the hospital for blood work or test or whatever kind of trial we're doing in that. So I think it's amazing that we're doing something on a national level. The one question I want to know, though, and I think it's great that, you know, to see, it's funny how lines cross with seeing both Stuart and Maureen as part of the transplant community, right? So what this CANTRAIN, is it going to be like all clinical trials? I know you talked about the one that's supported by CIHR, that's more about the muscular and arthritis kind of thing. but is this something that's going to expand into all areas of clinical trials? So that would be my question.
Okay, Sandra, maybe I can take that on. So CANTRAIN itself is agnostic to any disease process or any aspect of research in clinical trials. CANTRAIN's objective is to create training materials for those 4 streams, including the community and patient partners, about clinical trials. What are clinical trials? How do clinical trials run? How do you finance clinical trials? How do you write a grant? How do you co-write a grant? What about co-authorship, aspects relating to that? Stuart put on the chat right now, there is ACT, it's called ACT, Accelerating Clinical Trials Consortium. In the funding that came forward from CIHR, there's 7 or 8 different clinical trial training platforms, and then the national one, Accelerating Clinical Trial Consortium. But CANTRAIN specifically is agnostic to what the clinical trial is doing or researching. It's to get the information out there to students, to trialists, and those that want to, improve and move forward in the trial list, conducting trials, to those that are running the trials, and the community and patient partners, what it is, A to Z, anything about clinical trials. So I hope that answers your question.
No, yeah, I know. I see that now. And I also like the fact that not only are you talking about clinical, but because you're talking about patient engagement and how you're talking about that coming at the beginning of a person's medical career and research career, I think it's excellent. So kudos to you both and to CANTRAIN. So thank you.
Sean, I think you can go ahead and ask your question.
Sure, thanks. For those of you who don't know me, I'm Sean Delaney. I'm here in Edmonton, Alberta. Go Oilers. My question is a little bit based on Linda's comment in the chat, as well as Leonard's comment about, he has a background in computer science and things like that. And one of the challenges I find as a patient partner, especially because many of the projects, Ruth knows this well, I end up in are more in the basic science realm. It is antibody-mediated rejection. It is HLA and tissue typing. It's some of those areas. I think there's always a point at which we as patient partners, and maybe the team as a whole, also, we need to be very clear what we bring to the table, because I may only have enough information to be dangerous, and I need to switch my head from I'm not the professional in this topic area. I need to switch my head over to understanding what is the impact for patients, what's the benefit for patients, are we being treated fairly in there, and understanding our role. So I think it's one of the tough ones to navigate sometimes. And like I said, many of the ones I've been in are really in that basic science realm, which can be a challenge. I don't know, Linda, how you have navigated that in the past, because I mean, I'm also lifelong health care and lifelong patient. So
Yeah,
knowing when to draw that line, that I no longer have a science contribution, I am here for a lived experience contribution.
Yeah, it's tricky, and that's, the way I look at it is we have to equip people with a certain level of general knowledge that they can be able to not play the game, but play in the sandbox and get in partnership with the people that are going to be doing the research as well. So everyone in the research team has abilities and expertise, and everyone in the research team has areas in which they're not an expert and areas in which they're growing. So I think part of it is acknowledging that as everyone in the team, and there's ways to look at that also, ways to measure that, judge that, etc. And with a very good leader and facilitator, they're going to be able to have that going on too. That being said, I think in training, there's going to be different people that are just interested in this because they're interested in maybe their loved one is going through cancer treatment and is now in a clinical trial for the oncology disease that they have. And they just want to do a little bit of this and a little bit of that. So they want some a la carte training to help them understand this experience that they're going through, with life. Then there's going to be some that want to advocate for change at the federal level to create things that are easier, more transparent, maybe in health technology assessment, etc. So they're going to want to do some advocacy type courses. So we've really tried to take those aspects of what it is that people are looking for, their abilities, where they're starting from the foundation, and incorporate that overall into training. But I think a part of it is just as human beings realizing our limitations and what it is that we do bring forward, and then also learning from others that bring other things forward. So yeah, I hope that just kind of gives I think I'm saying the same thing as you, but yes, we have to do that. But have we taken that into consideration? I think the simple answer is yes, and there's different ways to do that.
Yeah, no, I agree with you wholeheartedly. The team wide, everybody, it's helpful to say what they bring and don't bring to the team. So there's some role clarity, but also the ability to bring in your other world experience.
Sherry, you can go ahead and ask your question.
Thank you. So I'm also a patient partner. I have a daughter that had a liver transplant, and I have such moved well, I've got many hats along with many of the other colleagues online, but I've just finished my MPH and looking into research and doing research as well. I just wanted to pull back to Patricia's comment in the chat about how common is training in trauma-informed practice for medical professionals. And the reason I ask that is because often when patients are involved in research in different stages, there are discussions of risks, and that can certainly trigger additional trauma for patients who are involved. And as a patient myself, and looking at being on the other side and running research, understanding the importance of not adding to additional trauma that patients are facing, have not maybe recognized certain risks involved in the actual project that they're involved in, how it can impact their own health and future health, both physical, mental, and other realms. So I like, Linda, you mentioned that, you hinted at that about the trauma-informed practice. And so I'm not sure if you can speak more to that, but I'm really happy that you're bringing that into conversation in the vulnerability of patient partnerships.
Yeah, well, thank you so much, and thank you for sharing that. I mean, it's a very important, near and dear aspect of educational need from my perspective, and I think it's sometimes acknowledged but not necessarily understood as well as it has to be. As to the direct question, how common is it? Not as common as it needs to be. It is out there. It is in different domains. I used to be a VP of clinical service in the integrated rural community. It covered emergency, a hospital, and 2 long-term care settings. And they had phenomenal rural physicians that worked in the ED that actually gave training in trauma-informed practice to the community of people that were there. And that was about 8 years ago. So there are aspects of people doing, I would say, some disease specifications, maybe cardiac disease, maybe heart and stroke, maybe oncology, or a little bit more ahead in the clinical realm of understanding the implications of that. I think, and this is just my personal opinion, maybe biased, from the clinical world to the research world, there's probably more trauma-informed education going on in the clinical world than the understanding of bringing it to the research world. So that's what I kind of feel. So I truly think if we're going to be talking about clinical trials to all audiences, that we're very interested, and we're working with a patient partner who's also interested in creating a module in trauma informed care and what that means vis-a-vis clinical trials. So that would be from my experience in different areas. It's a needed area. We need more on it. It should be taught in every single undergraduate health professional program. I'm not sure that it is right now, but I have seen changes and improvement over the 35 plus years that I've been involved in the healthcare world. So hope that answers your question a bit, Sherry. We're moving on it.
Thank you. Linda, I actually had a follow-up question based on that discussion. The recommendations you offered, are they consistent with the participatory action research, and did you conscientiously apply PAR principles there?
I'm not sure if you could clarify a little bit from the question, what recommendations, the recommendations that I was speaking to in my my presentation, or recommendations otherwise?
From your presentation.
Yeah, so the recommendations that I put there in my PowerPoint presentation actually come from very, very diverse sources. They come from lived experience sources of different people that I'm working on. I'm working in, besides CANTRAIN, 2 other research projects on a national perspective. So they come from there. They come from the literature. They come from what other people say, and they come from co-creating other patient engagement and education kind of, and research materials that really speak to these sound principles. So I'm not sure if that answers the person's question properly, but they come as to look at participatory action, I think was principles was part of the question as well. I would say what we are doing and what we seek to do in working with our partners with CANTRAIN follows principles associated with participatory action from a perspective of respecting, trusting, building trust, going to where people are at, etc. So I'm not sure if there's a specification if someone's actually looking for that I can speak to more, but that would be my answer kind of to that question. I hope it's okay.
I believe so. I don't think there were any further specifications given. So thank you so much for that. And with that, I'm going to say thank you to all of our speakers so far. That was such an insightful start to the meeting. We're going to have a quick break now to give everyone a chance to stretch their legs, and we will resume at 12:30. So I'll see everyone back here at 12:30.